record. Okay, so welcome everyone, and thank you for coming to our 7th BT Reach session. BT Reach, it stands for Virtual Teleconference, Reach, Explore, and Aspire to Careers in Healthcare. And we get the opportunity to talk to all different mentors from Vermont about their job, their career path, and learn all about them as a whole person and what brought them to where they are. And so you can reach all of our earlier sessions at our YouTube channel, BT Reach, and you can also follow us for updates on our Instagram, which is also BT Reach.
So thank you everybody for joining us tonight. And tonight's session will be highlighting some opportunities in cardiology. And we are joined by Dr. Cecile King, Catherine.Falduto, and Will Murdock. And they will be discussing their journeys to where they are today and daily life responsibilities. Dr. King is a cardiovascular medicine and in the fellowship program. Catherine is an interventional cardiologist, and William is an adult echocardiographer. So it'll be a super interesting session. We're really, really excited, and thank you so much for joining us tonight. And so without further ado, we can get started. And as always, just as you go along, put any questions in the chat and we'll address them within the Q&A sessions. So first up is Dr. King.
So hello, everyone. Good night. First, I want to thank Lily and Jillian for inviting us to come over and share our experiences in cardiology with everyone online with us. I hope that by the end of this discussion that we can maybe encourage some pre-medical students or even students anywhere in your careers to think about cardiology as a specialty. All right, so the first question that I think most people ask you if you even say that you're interested in medicine is people ask you what your inspiration was for going into medicine. And that question has come up multiple times throughout my career. So if I were to pick something that is the most tangible thing I could say that was my inspiration for going into medicine, it would be that during my teenage years, my father got ill, and I actually was lucky enough to go to doctor's visits with him. And kind of in that journey, I really, really thought to myself, I think I can give pretty good and thoughtful care. And I thought that I would be probably even better at giving empathetic care to patients. So that was actually the first tangible thing I can remember. My husband likes to say that I was always going to be a cardiologist. My mom says I wanted to be a cardiologist from the time I was born, but I don't remember that. So that was my inspiration. That was the tangible inspiration that I could find. And now I just want to move on to tell you guys a little bit about my pathway to cardiology. So as you guys know, there is a there's a long education process for getting into one of your subspecialty fields in medicine. So for me, I started out at Stony Brook University. That's a state university in New York. And while I was at that state university in New York, I pursued a bachelor's in biology. I actually started at that time doing research and getting really interested in chronic disease research. So I actually did research in diabetes during my time at Stony Brook. And I ultimately graduated, as I said, with that bachelor's in biology and also with a specialization in bioengineering. Very random, but I found myself kind of leaning towards it. So I specialized in that. After college, I actually thought to myself, more than likely I would do research. My mom does research. And I thought that that would be my path. So I went to Rutgers, previously known as UMD&J. I went to their graduate school and I did a master's in stem cell biology. In completing that master's in stem cell biology, one of the benefits about going to that program was that they actually allow you to take medical school classes too if you want to. So I actually got a chance to be exposed to medical school classes and kind of like PhD research classes so I could make a more informed decision of what I wanted to do, because I was still kind of toying with, is it going to be research or should I do something else? So after I did my master's in stem cell biology, during doing my master's in stem cell biology, I actually met a lot of people from the medical school at that time. And I got a lot of encouragement to consider medicine as a career. And ultimately made that decision, and I stayed there with that university. So I stayed at Rutgers and I did my doctorate in medicine there at Rutgers. As you guys know, that takes 4 years, but it is a really interesting time in your life. You get to explore a lot of different fields when you go into medicine, and then you really get to choose what fits with you best or what you enjoy the most. For me, I actually struggled a little bit towards the end of medical school. I thought about doing pathology because I enjoy sitting in a room and just focusing on details. So I actually really thought about pathology at that point. But I had a really good experience in my internal medicine residency and ultimately chose to do internal medicine. So I did internal medicine at the University of Wisconsin in Madison. Internal medicine residency is 3 years. And one of the good things about internal medicine residency is that then you have a wide array of subspecialties that you can choose from. So again, while I was in internal medicine residency, I continued to do research and I got introduced to my research mentor. And if I can leave you with any piece of information, having a good mentor is key. My mentor was actually a preventative cardiologist, and I did a lot of research with him during my time in residency, and I actually did a lot of clinics with him during my time in residency. And he really served to kind of make this cardiology look very, very enticing and like something that I would enjoy doing for my life. So at the end of residency, because of my kind of like interest in research, as you can probably hear from that description of my education path, I actually did an extra research year. So I did that research year. There are a lot of experiences or a lot of research experiences that you can have either during residency or after residency. I chose to do a government funded research year where the NIH trains you to become a true researcher and teach you about funding, how to get funding to do your research, how to do research effectively. So I did that for a year after residency, and my research focused on evaluating hypertension in young adults, because we know a lot about hypertension in older adults, but a lot of times our young adults tend to be underdiagnosed and undertreated. So I researched that for that year, which was a really lucrative year. At the end of that research year, I took a little bit of a different path, and this is kind of going to go into your work-life integration. At that time, my parents kind of had a few plans for their lives. They were going to transition back and move out of the state. So I wanted to be able to be there with them. So I actually took some time to practice as an internal medicine physician. So you can, the next slide shows that I kind of worked at Cooper University Hospital, and I worked as an internal medicine hospitalist at that time. So a hospitalist is a type of doctor that does acute care for a wide range of medical illnesses. So I worked at Cooper doing that, and that was actually a very, very helpful 2 years for me. I got to learn a lot about myself. I got to learn how to practice independently. So in other words, to make decisions without having someone there saying, yes, that's the right decision. So I did that for 2 years. And then after that, I finally made the transition back into clinical cardiology. And kind of that's where I am in my path now. I'm towards the end of it. I started a cardiology fellowship in 2019. And I am in my last year of a cardiology fellowship. As some of you may know, cardiology, like medicine, has a lot of different avenues that you can choose from. For me, and you probably can hear hints of this after I've told you my experience, but for me, I was always very drawn to the field of preventative cardiology. And on the next slide, I show a little bit about preventative cardiology. And one more slide for me, please. Thank you. So preventative cardiology always enticed me because it kind of incorporates all of those fields of training I had dabbled in before. So I kind of learned a lot about chronic diseases, so hypertension, diabetes. Remember in college, I said I researched diabetes, and then in fellowship, I researched hypertension, and I also researched smoking cessation. So preventative cardiology really, really spoke to me because I wanted to make sure that I could treat people before they actually got ill. So I do a little bit of the opposite of what Cat does. We still need cats in the world, but for me, I wanted to see if I could get those people before they actually develop heart disease. And that's something that I see myself doing in the future for long-term. The other thing I have on this slide is I talk a little bit about multimodality imaging, because that is another passion of mine. So in other words, we in cardiology have a lot of different techniques that we can use to image the heart and to non-invasively figure out exactly or figure out if there's some pathology going on and use that information to treat patients. So that imaging, that multimodality imaging, we say is multimodality because it could be CAT scanning, it could be nuclear scans, it could be MRI scans, or echo ultrasound scans of the heart. So I get to, Will did a wave there for us. So I get to incorporate all of those things into my day. I think it probably sounds a little bit daunting, but I promise you it is exciting. So I want to talk to you a little bit about my responsibilities as a fellow. So at this point, as I am a third-year fellow and kind of in my senior years of fellowship, my life is much more manageable. Sometimes in the early parts of medical training, you don't have as much flexibility, but for me, in my senior year of fellowship, the last year in fellowship is really for you to focus on the things that you need to learn to be the best physician, or for me, like the best cardiologist I could be. So right now I am training kind of to be proficient, or to be excellent, I should say, to be proficient in all of those imaging modalities that I described before. So I get to read echoes every day. I get to go and do nuclear imaging also, and I also get to do some CT education too. For me as a senior fellow, I do get to work with a lot of the other younger fellows on the team because I've kind of been through the process. So I get to assist them with understanding all of these imaging fields that I discussed. And another thing that I do, which I probably get the most satisfaction out of, is that I have a general cardiology clinic where I see patients in that clinic, and I'm able to assist them with a whole host of different cardiology problems. And that really kind of, again, is giving me confidence to be able to go out and practice independently at the end of this year. So talking about work-life integration, and I think that is always a really great question to ask someone who's gone through medical training. What do you do for work-life integration? As I said, because I'm a senior fellow now, my work days are actually pretty or predictable, I would say, because I do imaging. I do come in at about 7:30. I tend to, after I come in at 7:30, I review the cases that I have for the day. So in other words, the cases where I have to do a special type of echocardiogram where I go down someone's throat with a camera. So I review those cases and see who's appropriate. And after I figure out who's appropriate, we can get them scheduled to be done. So that's the beginning of my day. And then through the day, I'm really just kind of evaluating and reading these imaging studies as I discussed. And I usually am done with my day about 5 o'clock. And at this point, I actually don't have any calls. So I have my weekends off, and I have a lot of flexibility on weekends to be able to spend time with my family and my friends. Kat and Will know that I really, really like to bake. So my pictures are of baked treats because this is what I do. I like to see the perfection of a really fancy baked treat whenever I have time off. And lastly, I showed a picture of Antigua, where my parents currently live, and I kind of get to travel back there ever so often and kind of spend time on beaches like that, like deserted beaches with no one else there. And about half day a week, sometimes even more than that, I have clinic. So again, the clinic that I described before. So that is all about me, and I will hand you over to Catherine.Falduto.
Hi, so my name is Cat.Falduto. I'm a nurse practitioner with interventional cardiology, and I'm going to talk to you a little bit today about what I do in my role as a cardiology nurse practitioner, but also a little bit about my path that I took to get where I'm at today. So as Cecile was describing sort of her inspiration to going into medicine, mine's a little bit different. When I was finishing up high school, I really didn't know what I wanted to do in life. I knew that I really liked science and I really liked healthcare, but I wasn't really sure which avenue to take. I didn't really have any family members or friends that were in the medical profession, so I didn't really have a lot of guidance. So I decided to enroll in a 4-year traditional university, and I went to the University of Maryland, Baltimore County, and we can put the next slide up. I decided to study biology, and while I was there, I was considering the pre-med route. And, I was preparing to take my MCATs and preparing to apply to medical schools. And, for this whole process, you have to fluff up your resume a little bit. So I spent a little bit of time volunteering in local hospitals during my summer breaks. And it was really there where I kind of saw the role of different medical professions and how they operate in the hospital, who does what. And that's where I really connected to the role of the nurse. I really kind of fell in love with how nursing was at the bedside 24/7, taking care of patients. They were very hands-on. They were really empathetic and compassionate, and they really advocated for their patients. And I felt like I could do this really well. So I decided I wanted to go to nursing school. So I decided to finish my bachelor's in biology since I was almost done. And then I enrolled into an accelerated nursing program at the University of Medicine and Dentistry of New Jersey, which is the new Rutgers. And surprisingly enough, Cecile and I were at the same college at the same time, yet we've never crossed paths before, but now we've joined together at UVM again. So I did a 15-month accelerated bachelor's of nursing program. And this program was unique because it was only offered to people who had completed a degree as a prior bachelor's degree before in a different specialty. And you had to do a ton of prerequisite science courses, which I had already completed with my biology degree. So it was actually very convenient for me. This program is very vigorous, and we did a lot of clinical hours in hospital settings to basically train to become a nurse. So basically from 2011 on, I worked in various settings as a nurse. And I really loved what I did. I loved taking care of patients. But I felt like something was lacking, and I really felt like I could be doing more. I really wasn't kind of reaching my full potential as a nurse. I didn't really like being told what to do for patients. I wanted to be the one to decide what to do for patients. And so I decided to go back to school to become a nurse practitioner. So I ended up going to a university called Chamberlain, which was a 2.5-year program to get my master's degree in nursing. And this program was really convenient for me because it allowed me to still work full-time as a nurse while I was completing it. It did have a very strong clinical component of completing about 700 clinical hours with a preceptor who was a nurse practitioner in various settings, basically teaching you how to assess, diagnose, and treat patients with complex comorbid conditions. And I graduated from that in 2018. And then I landed my dream job in cardiology, which I'll talk to you a little bit about later. But from then on, I still felt like I needed to learn more. I recently went back to school again, and I completed a postmaster's certificate in acute care at the University of Pennsylvania. And I think what's important to know that is when you go into any sort of healthcare profession, when you finish school, you're never done learning. You've basically committed yourself to a journey of lifelong learning. And whether that be going back to school or like continuing medical, like education credits or anything like that, you've kind of committed your life to learning forever. Things are constantly changing and evolving in healthcare. And I think that's why most people are in healthcare, because they enjoy learning new things and innovation. So I put some question marks here because I'm probably going to go back to school again in the future. For nurse practitioners, a lot of the organizations are recommending that all nurse practitioners have what they call a terminal degree, which is either a doctor of nursing practice or a PhD in nursing. And so I suspect probably in the next few years, I will go back to school to get a doctorate. But I'm taking a little break right now as I've spent the majority of my adult life in college. So the next slide just shows a little bit about kind of my career path. As you can see, I've spent about 8 years of my life as a registered nurse. I've worked in hospital settings, I've worked in hematology, oncology, I worked outpatient, and the majority of my career in nursing has been in cardiology. And that's kind of where I've felt the most comfortable and I enjoyed it the most. So since 2018, I started my job as an interventional cardiology nurse practitioner at the University of Vermont. And I think the next slide will tell you a little bit about some of my responsibilities and my role there. It's really hard to kind of describe what I do for a living. I do anything and everything they need me to do. I'm sort of the go-to person whenever anybody needs something related to an interventional patient. If I can't help them with it, I know somebody who can help them with it. Mostly I manage pre and post-procedural care patients in cardiology. And so these are patients that come in with heart attacks, that go for stenting procedures, and patients that get structural heart procedures such as valvular procedures of the aortic valve or mitral valve. And I really kind of oversee their care from admission to discharge. I optimize their medications, I facilitate discharging, and I manage any sort of complications that may arise after their procedures. A big part of my role and something that I think is really important and I really enjoy doing is patient education. And I think anyone who's going to become a nurse practitioner has to feel strongly about patient education, and especially in cardiology. And I know Cecile is very on board with this as she is very into the preventative side of things. But patients come in with heart attacks and we fix them with stents, and then they typically go home the next day. We treated their blockage with a stent, but we haven't cured their heart disease. And so a lot of times patients don't realize that. They think they're fixed. But there's a whole lot of teaching and counseling that is needed for these patients to go home and be successful with their care. They have to make a lot of lifestyle changes with their diet and exercise. And we recommend they take their medications appropriately and follow up with cardiac rehab. So a lot of my role is spent counseling patients about these really important changes that they should make in their lives. Another big part of my job, and which is kind of my day-to-day operation right now, is I act as a first assist in the cath lab. And so basically I scrub into heart catheterization procedures. These are the procedures where patients come in to get stents. And I also scrub into some structural heart procedures, something we call TAVR, which is an aortic valve procedure. And basically, I act similar to an interventional cardiology fellow. I obtain access, vascular access for these patients, whether arterial or venous, and I assist with the diagnostic and interventional parts of the procedure. I basically work one-on-one with an attending during these cases. It's a very exciting role. It's a very stressful role. I've learned a ton being here. And honestly, I couldn't imagine doing anything else for a living. I live for the thrill of this job. Another big part of my job is I do a lot of teaching with the interventional cardiology fellows as they are onboarded. And so a lot of the first and second year fellows do month rotations in the cath lab. And I work with them one-on-one to kind of go over equipment and kind of explain the flow of the cath lab. And I'm there for kind of any issues that they may have. I also work with a multidisciplinary team. I work with 6 interventional attendings. I work with many nurses, cardiology fellows, nurse practitioners. And I think this is one of the most, like, the best parts of my job is I just work with a great team, and we're all there for the same goal at the end of the day, and that's to take care of the patient. And so I really love the people I work with. I think that's one of the most important things about having a job is enjoying going to work, enjoying the people you work with. And a lot of these people are like family to me. Cecile and Will, like, we all hang out outside of here, and, you know, we're not just coworkers, we're also friends. So I think that's really important. I also help a little bit with any quality improvement projects that I may be interested in working on. Right now, I'm working on developing a packet of information for patients after they get stents done to kind of go over a lot of these lifestyle changes and kind of highlight the more important things that they need to work on. And we'll go to the next slide. And a typical kind of, this is my work-life integration. And so a typical work week for me, I usually work Monday through Fridays. I come in around 7:30. I typically leave around 4:30, sometimes earlier, sometimes later, depending on the day. I usually scrub in the cath lab about 3 to 5 days per week. I share kind of the schedule with the interventional cardiology fellows that we have. We currently have 3, so I basically kind of split rotations between the 4 of us. I usually have 1 day a week for admin duties, and I also help out with the management of the patients on the floor for discharging. And part of my role, actually, I have to take call, and this is for emergency patients who come in with heart attacks. So heart attacks don't just happen during business hours, they happen in the middle of the night, they happen on weekends. And so I typically am on call 1 weekend per month, as well as 1 night per week, where I have to be in the hospital within 20 minutes of getting paged for an emergency case. And it's a lot of working, it's a lot of hours, it's a lot of stress, but I have a lot of hobbies and things that I do in my off time. I like to run, I'm a runner. I recently ran a marathon, so that's a picture of me completing my first marathon 2 years ago. I'm really into skiing. My husband is actually a full-time ski instructor. And so that's a picture of me skiing. And then we recently bought a house and I got into gardening. So I think I'm doing okay. So I think that's about it.
Hi, that's me. Hi, I'm Will Murdock. I'm a cardiac sonographer. I work with Dr. King and Kat at the hospital here. So a lot of people don't know what a sonographer is. Basically, I use ultrasound to look at hearts and help diagnose heart conditions with the help of Dr. King and Kat as well. A lot of people don't know about the field. I'm pretty sure my parents have no idea what I do. They just think I work at the hospital, which is kind of fun. From there, I'm from a small town in Louisiana, middle of nowhere, Louisiana. It's all farming and agricultural. From there, I actually left my hometown and moved to Baton Rouge, Louisiana, and got my degree in cardio. Sorry, go next. Oh, thank you. And so I actually got my bachelor's degree in biology at LSU in Baton Rouge. When I first started there, I was actually looking to not understand like what I was going into. I just knew I was really good in biology and sciences, and so I got into research and studying that for a long time. It wasn't until my 3rd year in school that I realized, oh hey, maybe research every day is not always perfect. Let me try something else. So I helped to co-found a global medical brigades chapter at LSU for their students as well. And through that, we were actually able to visit, many, third world countries such as Nicaragua, Panama, and Ghana, I think it was. And through this experience, I actually gained insight into actually a love of medicine, working hands-on, one-on-one with individuals, people who needed help, people who were hurting, and I just fell in love with helping people, And from there, it solidified my resolve to work in medicine, to help people, to find a way to save lives and impact others who needed help and didn't understand for themselves what they wanted or what they could do. People who were scared. And I feel like that's kind of how everyone feels in medicine, is to help others. So to do that, I went and talked to my advisor, told him about my schooling and whatnot and what I hope to do. And we kind of made the joke back and forth that much like bad jokes and diabetes, cardiology runs my family. Cardiac issues run my family. So he helped me find sonography as well, because I didn't feel like going to medical school for 4 years, because that was kind of daunting and scary for me at the same time. Unlike Dr. King, who thought she could do better at 13 years old. And so I graduated with bachelor's degree in biology in 2016, in May of 2016 in Baton Rouge. And then in June of 2016, began school immediately after at LSU School of Allied Health in New Orleans. From there, I did 2 years there, got my second bachelor's degree in cardiopulmonary science, which is just a fancy way of saying heart and lungs, which was nice. While in school in New Orleans, we actually met and did a ton of work at many different hospitals down there, including multiple level 1 trauma centers, small clinics that only included like a dozen people, maybe max. And so with all this direction and education and things like that, I was able to study research also down there and get into TTEs and TEEs, which is nice. And the TEE is the one that Dr. King was speaking about earlier, where they actually take a camera and go down someone's throat to better view the heart. In that case, the reason they do that is because we can't have a great transthoracic view of the heart. We have to get a better view from within inside, since the heart sits much closer to the esophagus and is not blocked by bone. So going on from there, thank you. Some of my responsibilities as a non-invasive echo tech include the TTEs, which we were just discussing, the TEs as well, and including stress tests, which I did a bunch of those today, which was nice. What that entails is taking a patient and putting them on a treadmill, and every 3 minutes increasing the height and speed of a treadmill until that patient gets to a certain heart rate or tires out, and all that. And what we're doing in that case is stressing their heart out as much as possible, so that we can kind of get a sign if there might be a ischemia or blockage in their heart, that we can kind of look at it under ultrasound very quickly. We have 90 seconds to view their heart and do that. And so it can be an early indication that this patient might need a cath in the future or something else, and then they go through a slew of other testing as well. We also work in valve replacement and repair assessment of certain valves. One thing that the Master Cat was talking about was TAVRs, which is a transaortic valve replacement, which is essentially when they take a heart valve, go for the groin, and put a new one in for the patients who have very stenotic valves or valves that aren't working properly. Those are always fun to see and be a part of. Team-wise, we have to view those valves under echo, because we have to be able to see, make sure they're seated properly in the right position, and also opening and closing properly as they should. Part of my background is in research at LSU, and because of that, my boss would love to have me up here because of that. We actually not work with just labs from around the country, but around the world, working on these next-gen technology and techniques to better out the outcome of patients who are, having other issues that may not be able to get normal or precise care that way, which is fantastic. I mean, I love talking to my research fellows from around the world and some other cases and things like that. I'm the guy who enjoys reading research papers at home like a psychopath, apparently. And so that's basically my daily technique, my daily routine and stuff like that after going to work and doing all these things and all that. But what's really cool is I actually get to work with Dr. King and people like Kat every day, and we kind of sit down and talk about certain cases and what's going on and what might the outcome be and what we can kind of do to have the best outcome for these patients in the future, and what we might be able to do to prevent worse things from happening or better educate these people, especially because I spend 30 or 40 minutes talking to a patient as they come in for each day. And so moving on. And so we're talking about next slide, my work-life integration slides. I'm kind of a goofball, so I like to put photos like the top left one of me and my lad going to TAVR, looking at things like that, looking at the valves and all that. I'm a big foodie. I love food. Dr. King can tell you about that. And she is a phenomenal baker. She is not lying. And then once again, my typical work day starts at 8 a.m. I'm there usually about 7:30. And I'm sure Kat and Dr. King can tell you about that. They say 7:30 a.m. They're usually there by 7. Don't let them lie to you. They're there early in the morning and they're there after 5 p.m. some days, which is phenomenal. It's a great time. It's not because they have to be there. They want to be there. They enjoy being there like me. When I wake up in the morning, it's the first thing I can't wait to get to is to work, to see what the day brings, because every day is a little bit different working in sonography. you see some of these crazy cases and things like that, and it's not the normal cases that get you, it's the ones that are kind of obscure and different. And so my typical work day is 8 to 4:30, and I do all my normal workday stuff. My weekends usually off unless I'm on call or snowboarding or something else. I love traveling. The picture to the right of me with that reindeer is actually me in Finland pre-pandemic. I was up above the Arctic Circle hanging out with the reindeers and seeing Santa Claus, all those fun things. It was funny because it was actually colder here in Vermont for one of those days than it was. I think it was like -20 here, -19 there, something like that. And then whenever I'm not doing that, I like to relax and read on the beach. And I think that's up next. All right.
Thank you so much, all of you. So I'm going to just bring you all up, and then people can add questions to the chat. I know Lily and I have some questions as well. And I see our first question for all three of you is, how has COVID impacted your daily job and your joy?
Cecile, do you want to take this one first?
Sure, I'm happy to. So I think that we are pretty lucky here in Vermont because even at the onset of the pandemic, our case number was still on the lower side as compared to many other states. At the time of the onset of the pandemic, we did see some changes in our daily workflow. So in other words, as the pandemic was actually peaking, we did have to cancel any cases that were not emergent. So in other words, anyone who was just coming into the hospital for an elective procedure. So in other words, something like the TAVR, the transaortic valve replacement, or something like a stress test that could have been put off for maybe for a couple more weeks or months that the person wasn't so ill, we did have to cancel those elective procedures. So that was one thing that changed with our day-to-day. I think that overall, our department still has continued to work at its very, very close to its normal level. I personally think that COVID actually did develop my skills a little bit more as a physician. You get to see some interesting new pathologies from a cardiology standpoint. So in other words, we had people coming in with, and Kat can probably speak to this a little bit more, but with like more heart attacks from clots or from thrombosis or changes. Sometimes as we're reading echoes, we have to ask ourselves, is this change in the heart muscle function something that we normally see, or could it be associated with the COVID pandemic? There was a very small percentage of people who had some heart muscle changes that we kind of asked ourselves that question. But overall, at this point, I think we're back to functioning normally. And we were lucky enough, because we're in Vermont, that I was not at any time personally like extremely stressed out about coming to work. We all took really safe precautions with all of our procedures. So overall, I felt like if COVID did not negatively impact our practice and actually was not too worrisome for us. I don't know if you guys think differently.
Yeah, I agree. I think we were pretty well prepared in Vermont, kind of with the way that we handled COVID from early on. We did have like much less volumes during the early stages of COVID, so we didn't have a lot of the outpatient elective procedures like Cecile was saying. I do think there was a little bit of a shift of more like kind of critical, sicker patients coming in. And that was maybe more for fear of them seeking medical care earlier because of their worry of COVID. So they're coming in with really bad heart attacks that could have been kind of intervened upon sooner. And so they kind of just delayed treatment because of their own fears about COVID. But I think we have like a decent handle on it right now. And we have a lot of policies and kind of procedures in place right now to kind of protect us and protect patients.
Yeah, I agree completely. We felt like we're lucky here, kind of in a bubble in Vermont, actually, opposed to other places like New York and California, which had, tons and tons of volume coming up COVID cases, versus here, there's only 600,000 people in the state, and we're all kind of spread out everywhere. So our volume did decrease here for a while, and then we started seeing those heavy cases come in that were more severe just because of boarding issues. I mean, they were coming in and having more severe cases in general because they're waiting to come in instead of coming in earlier on because of fears.
Wow, thank you so much for, obviously COVID has impacted every healthcare profession, but it's still always interesting to hear what specialty is, how they've tackled it as well. Another question from the chat from Jenna. They say, you all have amazing backgrounds and stories. And what advice do you have for students who have interest in numerous specialties and do not really know where to start or where to go?
So it was Jenna, right?
Yes.
Hi, Jenna. You are actually asking the best question. That is a really good place to be. I would, the piece of advice I would give, and it's kind of going back to what I alluded to before, is I would try to find a few people in specialties that you might have interest in, and spend some time with them and really ask them kind of like a lot of the questions that we tried to answer in this talk, like ask them, what does your day look like? What makes you want to wake up and come to work every day? With kind of asking them some of those more poignant questions and spending time with them and seeing what they do in each of those specialties, I actually feel like you can figure out what you are most drawn to, because they're going to be things that you love to do. For us in cardiology, we all are very passionate about the heart. We love what we do, right? And I think that for people who are drawn to cardiology, when you come and you spend some time with us, you can feel that, and you can decide if it is a field for you or not. Most of the fields in medicine do take more of your time, so you have to make sure that you truly are passionate about whatever you choose, and good mentors to ask any questions you may have. People who are not afraid to truly tell you how they feel and tell you the truth.
Thank you. And then we have another question for Kat from Heather asking, did you ever consider the PA route instead of the NP? And if so, what makes an NP seem more like a better choice for you specifically?
Yeah. So for those of you that don't know, both PAs and NPs kind of have similar roles in terms of kind of what they do for patients. They can diagnose, they can treat and assess patients basically mostly independently. Actually, PAs I think need a physician oversight, whereas in different states, NPs don't always need a physician oversight. For me, I started my career off as a nurse and in nursing, and so it just kind of made sense to kind of continue along that path to become a nurse practitioner. I was kind of already invested. I didn't really consider the PA route, but I could see people that didn't spend 8 years of their life in nursing before to go into the PA route. So I think they're both equal in professions. I don't think there's much difference between the two roles.
Okay, great. The next question we have is, how would you all recommend reaching out to different doctors and specialties that students are interested in? Is email or in person better, especially if they have, you are also busy, have a lot on your plate, and sometimes it can feel for us students that it might be like burdensome to ask to shadow or things like that. So what is your best recommendation?
I think I've worked with numerous students and even just nurses kind of interested in maybe going back to NP school. And so I think just like reaching out with an email and like telling them a little bit about themselves and, why you're interested in maybe pursuing this kind of path. I think that would be helpful. Obviously, if you know anybody like friends or family that have connections in healthcare, I'm always happy to work with people, and feel free to email me anytime if you're interested in being a nurse practitioner or in cardiology. But I think just emailing, reaching out, just showing interest.
Yeah,
I completely.
Sorry. Yeah, absolutely. There are actually tons of doctors I know who would love to have students come in and just work with them for the day and show them around. I mean, I don't think I would know a single doctor who wouldn't love that, actually. Dr. King.
No, I was saying I completely agree with Kat and Will. For the most part, we always love having students around. I know it can feel daunting to have to email someone you don't know, and you think that they're so busy they might not be able to make time for you. I understand that concern, but I would encourage you to find, if you find a physician, or if you find anyone in the field that you are interested in, that you find to have you find the specialty that they practice interesting, and you want to spend some more time learning about it, I would just email them. And if they don't respond to you the first time, I know this is uncomfortable too, but if they don't respond to you the first time, you can always send a follow-up email and say, hey, I'm reaching out to you again. I am very interested. And for me, when I see that often, I usually do say, okay, this person is truly interested in spending time learning about the field. The other thing I would recommend is, as you choose people to reach out to, try to do some research on them. So in other words, try to see what they do or what their interests are. Because a lot of times when you send that email, you can say something like, okay, so for me, Kat and Will know this about me, I love prevention. If you email me and say, hey, I really love prevention too, I'm probably going to respond to you probably more readily than someone if they email me and say, I like nephrology, right? So I would say, making sure that you learn a little bit about that person's background so you can truly kind of leverage that in your conversation. That's one specific recommendation I would give. And another one I would give is, don't be afraid to even speak to someone. Say if someone's over teaching a class, if one of us is over teaching a class in the medical school or giving a lecture like this, always feel free to reach out. You can either speak to them verbally if we ever do things like this in person again, or just always like email that person and just say, you really enjoyed whatever they did, and just email. As Kat said and Will said, we are always willing to help. We're happy to have students. You probably would just have to listen to us talk a lot. That's all.
Thank you so much. Yes, definitely email and ask. Lily and I were able to even start this program by just emailing Dr. Mariquin and saying, look, do you want to do this with us? And she jumped on board. And so our next question for Will, what traits or interests would be a good fit for a career as a sonographer? And I was also just wondering if you knew a little information about how many really programs there are in this country.
Yeah, absolutely. I would be happy to tell you about it. First one is, do you enjoy watching TV and being on time all the time? No. So as a sonographer, you actually spend a lot of time in the dark, because we have to look at these screens and notice small, fine details about things and all that, which sounds horrible, but it's honestly fascinating, because you get to take your time and look at someone's heart and kind of like sweep through two-dimensionally a 3D object, and you look at it as it comes along. And seeing normal hearts is easy. You can do it, in a few weeks, but it's, the strange things you like. So if you enjoy finding weird things, or kind of like searching for something, playing I Spy maybe, these are some great hobbies and tasks to bring forward to this field. We love having students come in and do all that. We actually have a couple of students who are being mentored now to be sonographers. So if you ever want to reach out, we're happy to have you come in and check it out sometime.
I actually shadowed with Will for a few days as well, because I wanted to learn more about echo myself.
I also have shadowed with Will to learn more about echo.
So I actually had a question, just hearing the three of you talk about, especially Dr. King, about preventative care, just in specifics to cardiology. Have you noticed in just maybe your work at the med center and things like that, of a push for more preventative care in other healthcare fields or specialties as well?
Yeah, excellent question. Overall, in kind of like statewide and through all of the states in the US and through the medical field, there has been a very, very big push towards prevention. So in other words, there are a lot of even like medical schools and residency programs that are truly looking for people who would want to either go into primary care or going to some field where prevention is a very big part of the field. I think overall people are starting to realize that if we can prevent a lot of the more critical illnesses, so in other words, if we can manage risk factors and prevent things like heart attacks or strokes, or even prevent progression to diabetes or bad high blood pressure, if we can do those things, we actually can overall improve the population's health. So whenever someone tells you they do prevention, that means they also have some type of interest in population health. And when I say improve population health, I mean of population health of the US. So we have a lot of programs throughout the US that really do push for trying to do more prevention, do more primary care, do more early care, and kind of like, I guess, early identification of risk factors and modifying them. I hope that answers your question, Lily.
Yes, it did. Definitely. Thank you.
And I had a question for Kat. You talked about how you do a lot of counseling people with lifestyle changes. And I was just wondering if there's any challenges that come with that, or just pushback from patients, or how you really deal with those difficult situations in just the cardiology field.
Yeah, a lot of pushback. You know, it is very challenging to kind of convince somebody to make some lifestyle changes, you know, when they're in their 70s and 80s. They've been doing kind of living like this their entire lives, you know, but I think it's a really important time when they're in the hospital right after kind of a crucial event like a heart attack to kind of start having those conversations, because they're more willing to kind of maybe make a change at that point in time. So it is definitely a struggle to kind of get people to make changes, you know, but it's kind of working on one thing at a time. And so if we can kind of make, you know, small adjustments to their daily life, and hopefully that can impact them long term.
Thank you.
So there's one more question in the chat, and then I think we will move on from this Q&A, but we will have a second. So feel free to continue asking, and any questions will be addressed. But for now, this will be the last one we're asking. This is from Kayla, and she says, have personal life goals ever made you second guess yourself in going down this path, especially in terms of how many years of schooling? How did you go about making those types of life decisions for, you know, these years upon years upon years of school?
That's a very good question. So much so that I'm trying to think back to those times. So I think that anyone who's gone through medical training, if they're telling you the truth, they will say that they were always moments where you say, you know, the late night studying, or, you know, your fellowship or other things. They might actually say to themselves, yes, is this truly worth it? And when, for the times that I've had that question, the times that I've asked myself that question, I think I always still came back to the fact of, is there anything else I would want to do? And because there was not much more that I thought I would be ultimately happy doing or enjoying, I as much as I may have had a moment of second guessing, if you're tired and on call, I think those were all just very, very temporary states. There was nothing that was ever prolonged, for me at least. But I do think that, yes, there are different things that might make you second guess. And I'm actually looking at your question again, Kayla, and I think you're saying have personal life goals. So let me, I think I was not answering the exact question you have. So personal life goals, at this point, because I did a lot of my training very young, my only goal was to finish training. So there was no specific personal life goal that made me second guess myself. I think as I get a little bit older and my husband starts to go, hey, babies, I think at this point, I did say to myself, I think I'm done with training, because there are a lot of different additional training routes that I could have taken at this point. So you actually could go much further into cardiology. And I think after kind of thinking a little bit more about my ultimate goals to still be able to have a healthy and happy family, I thought that moving on from training would be helpful.
Yeah, I think it could sound scary, kind of listening to us and kind of the years and years of education that we have done. But that, you know, there are moments in time when you're going through this and you're like, what am I thinking? Like, why am I doing this to myself? But like nothing, like it's worth it in the end. Like it is worth it in the end. And I feel like where I'm at right now, I'm so happy, and I would never have, you know, like I'm glad I pushed through it when I did. And you know, I've kind of accomplished many things in my personal life too that I wanted to accomplish as well. And I don't feel like my schooling or kind of my professional life impacted that much at all. And I feel like if it's important to have a supportive family, I have a very supportive husband who kind of listened to me struggle through all of my years of schooling and all these new jobs. And but yeah, so it's important to kind of have a good support system to kind of get you through these things too.
Yeah, absolutely. I mean, work-life integration goes back to that. While we do work a lot, I mean, the thing is we have these lives that we do live. I mean, traveling, baking, running marathons, things like that, that all kind of help us cope with, you know, each day. And yes, like Dr. King and Kat were saying, you have those days of doubt, but when you see one of those patients who you've helped personally walk out those doors and are living a better lifestyle, it honestly makes everything so surreal and like it worth it in the end. And so honestly, I don't think I could find another field or career in medicine or somewhere else that I would rather be than in cardiology or working medicine.
Thank you so much. You guys are also passionate, and it really shows. We'll just move on to the case study and let you, the three of you, talk about how you get to work together and work with each other as friends, which is such a great aspect of your job as well. And so then any other questions, like we said, can go in the chat and we'll address them at the end. And so I'll let you take it away.
So a lot of what we do as a cardiology team really means bringing all of our specialty skills together to make sure that we give patients the most effective care that we can. So for us, for our group, a lot of times the process that we follow is that, say, a patient will come in, they will get whatever testing done, whether that is a scan or some other type of testing. We tend to have someone who analyzes that information. We will always have discussions amongst ourselves, like so amongst the group. And then after we have those discussions and kind of integrate that information, then we can make a pretty sound diagnosis, figure out what's going on, and then plan to treat it. And I think in general, we work really well together in cardiology because we follow this process. So we wanted to kind of take you guys through a case to really show one of the things that we deal with very often, one of the pathologies we deal with very often, and also to show how we kind of work together as a group and follow this process. So I'm going to give you guys kind of like next slide. I'm going to talk about the multidisciplinary management of a cardiac case. And I'm going to treat you like you are in medical school. So we've kind of presented it the way that we discuss cases. So in other words, with the same lingo that we use if we're discussing a case. And then we're going to take you through what we actually see, and then take you through how we treat the patient at the end, and hopefully come up with a good solution. All right, so next slide. So 65-year-old male with a history of long-standing tobacco use. So in other words, he smoked for many years. He also has high blood pressure, which he doesn't take any medications for, so is uncontrolled. He also has high cholesterol, and he has diabetes. So this 65-year-old presented to the ER complaining of left chest pressure. So whenever someone comes in with that kind of left chest pressure, they always get an EKG, they get lab work performed. And for this individual, a lot of the lab work resulted showing evidence suspicious for a heart attack. So the patient got admitted to our cardiology service. And after they were admitted to cardiology service, we usually start them on appropriate medications. And one of the first steps that we do for these people, if we have the luxury of it not being emergent, we like to start with a transthoracic echocardiogram. So that just means an ultrasound kind of like through the chest. So that was ordered for this patient. And we can go on to the next slide. And so that was ordered for this patient. And we have a real-time picture of Will doing his job. So I'll hand it over to Will.
How's it going, everyone? I'll just take over. So as Dr. King was saying, if there's time and time permits, and it's not an emergent case, we like to do an echocardiogram to start out with. What happens is we end up coming in the room and spending about 30 minutes with these patients, sometimes more, sometimes less, depending on what we're looking at. And in this case here, we're looking for an MI, or a myocardial infarct, or a heart attack, basically. And so when that happens, a vessel in the heart is basically blocked by whatever, and the muscle and the heart begins to not work properly or squeeze as it should. So when we go in the screens and we begin pressing on the patient's chest in multiple points of view, we're looking for any abnormalities in the muscle itself, whether it be not contracting properly or structurally damaged, things like this. And so what's really cool about echo is we're using a 2D screen, but we're looking at a three-dimensional object. So the reason the scan takes so long is because when we take our probe, we have to look at it from multiple points of view and slice the heart in multiple angles. That way we make sure we're not missing anything. So we're scanning up and down, looking from different points of view. That way, if something happens somewhere, we can get a really good look at it. So I think if we're going to move on to the next slide, we actually have a case. And Dr. King will kind of show and talk about this next. Once I do my study and we have these images here to our left, we can see that there are points of interest that are a little bit not working properly, and I'll hand off to Dr. King. Here.
Mm-hmm. Yeah, so as Will said, after he obtains these images, they get pushed over to another computer where we sit and we actually kind of analyze the images in details. So for this case, because we were suspicious for a heart attack, so in other words, we were suspicious that there was a blockage somewhere in the tiny arteries of the heart, stopping blood flow to a certain region in the heart, because we were suspicious for that. The main thing that we try to look at in the echocardiogram is really to look at how the heart is functioning, what the heart structure looks like, and we're able to identify if there's an abnormality consistent with MI. So if you can play the first image for me. So for this image, as Will was explaining, the images are taken at a lot of different angles because we use all of those different images to come up with a unifying diagnosis or a unifying read. So this is actually like a really cool case and a really good picture. So this is a picture that is taken like if you were slicing through the heart. So in other words, the heart is kind of like a conical shaped muscle. And in that conical shaped muscle, there's a cavity in the middle. That cavity, there's a cavity on the left side and there's a cavity on the right side. For this one, we're focusing on the cavity on the left side. And if you guys can kind of look at that picture and see that we are looking to see how the muscle kind of thickens up as the heart beats. So I hope that you all can kind of appreciate that the thickness of the muscle, so the thickness of that donut on the top is much, it is much thicker on the top than it is on the bottom. So that makes me suspicious as I'm reading that this is some type of heart attack or blockage that is stopping blood flow from getting to the inferior or like the bottom part of the heart. That is what this first image is very suspicious for. And I hope all you guys can kind of appreciate that donut as it squeezes, and seeing that the bottom portion is not squeezing and that muscle is not thickening up as you would like it. A way to kind of simplify it is thinking about your bicep muscle, and as you flex, I don't have any, so I'm not going to do that. But think about your bicep muscle as you flex it. It kind of has to contract, right? It gets smaller and then it extends. That is what a normal muscle does. With a heart attack, the muscle does not work normally, and it cannot do that contraction as nicely. So this is a really kind of like clear version of that. If you click on the picture on the bottom, again, this is cutting through the heart, but this is cutting through the heart almost vertically. So in other words, you're cutting through that conical shaped chamber vertically. And again, we're looking at those walls and looking at how everything is thickening up. And you can see kind of on the outskirts that wall is not thickening up as nicely as it should. Again, making you suspicious that there might be a blockage in an artery that takes blood flow to the bottom part of the heart. So when we see something like this, so from the time Will does his scan and he sees this, he usually runs downstairs and says to me, so for this patient, he ran downstairs and said, you know, there is this kind of change. Can you take a look at this quickly so we can figure out what to do? So we take a look. We both agree that there is a change in the heart muscle. And from there, we have a discussion with the interventional team. So you can go to the next slide. So again, a lot of cardiology, especially when the cases are more complex, is about these multidisciplinary discussions, because we have a lot of different disciplines within cardiology, and we all have our specific jobs to make sure that we can do things very, very well, because we all get very good at our specific roles. So after having that discussion and saying, hey, you know, we have this guy, he came in with a heart attack. We see these changes on the echocardiogram. It looks like if he has a blockage and is causing a big problem. We usually have that discussion with Kat and the interventional team take over from there.
Go
next slide.
So basically, you know, Will has done this echocardiogram and evaluated the patient, and Cecile has interpreted these images and found evidence of the heart muscle not moving very well on the bottom wall of the heart, which is suspicious for a heart attack in that territory. And the good thing about kind of having these images and information is it really kind of helps guide our treatment in the cath lab. We already kind of go in knowing kind of what we're going to find. Each of these different territories of the heart is correlated to a different coronary artery. And so basically your heart arteries sit on the outside surface of the heart. And so your heart's here and you have 3 major arteries. Most people have 3 that sit on the outside surface of the heart. 2 are on the left and 1 is on the right. And so in this patient's situation, the inferior wall is supplied by the right coronary artery. So we already went into this situation knowing that this patient may have a blockage in the right coronary artery. So when the patient comes to the cath lab, I typically will talk to the patient about the procedure, why we are doing this procedure for them, why we think it's important to do, and kind of go over all of the risks of the procedure as well. When we bring them into the cath lab, we typically obtain vascular access through an artery in their wrist or their groin. And basically we thread a tube or a catheter all the way up to their heart. And from there, we inject a contrast dye through the catheter into the coronary arteries, and that will actually light up black on our X-ray pictures. And so we can see if there are any narrowings or blockages in the vessels. We can show you in the next slide. We have some pictures of this patient's films. And so basically in the upper left-hand corner of this image, you can see the small like kind of L-shaped catheter. That's the little plastic tube that we have in, and we're injecting dye and it lights up those coronary arteries black, and you can see everything's moving because the heart is beating, and you can kind of see the flow down all of those vessels. These are the 2 coronary arteries on the left system. And there's no real significant blockages. There's some mild plaque here and there, but nothing really serious or significant that we need to fix. I can show you the next image. And that is the right coronary artery. And you can see this one looks very different than the other ones. You can see kind of in the mid segment there, there's a very, very tight narrowing, and that's a blockage in this patient. And they actually don't have very good flow distal or past that blockage. And so this blockage is plaque or cholesterol in the artery wall. And also patients can have clot or thrombus inside there as well. So for this particular patient, we can go to the next image. For this particular patient, we thread a very, very tiny wire down that artery through the blockage, past it. And then we use stents and balloons. And it's sort of on a monorail system. So it goes up to where the blockage is and we inflate the balloons. And that helps us to deploy the stent. And basically the stent is just pushing the plaque up against the artery wall. And it allows the artery to kind of open up and allow blood to flow freely down the vessel. And so these are kind of stents and balloons going in. And then we can show you the next image of kind of the after of this patient. And you can see how big that artery really was and how much blood it's supplying to that huge inferior wall. And so this patient needed to come to the cath lab and needed to get fixed. But like I said, we fixed that plaque and we just pushed it up against the artery wall. We didn't remove the plaque. We didn't get rid of it. We didn't cure their heart disease. So this is where we kind of continue to have these conversations with patients that, yes, we treated your blockage, but we have not cured your heart disease. And these are things that we have to continue to manage. So this was sort of a successful case from the three of us that we worked together on. And it was a really good outcome for the patient. So I think that's the last slide, was it? Yeah.
Thank you so much. Oh, no, sorry, continue.
Oh, no, that was the end of the case. You're correct.
It was really such great images and videos that you all shared. So that was like really, really incredible to see. So thank you so much for sharing.
So yeah, thank you very much for having us. As you could see, there are a lot of different areas under the cardiology umbrella, and a lot of different opportunities to have very fulfilling careers in the field of cardiology. One of the very helpful things about cardiology is that within most of its subspecialty fields or most of those subfields, most people can find something that they're very, very passionate or very interested in doing because the field of cardiology is so vast. Today, we were happy to kind of introduce you to interventional cardiology and imaging, specifically echocardiology. But there are a lot of other fields within cardiology. There's sports cardiologists. So there's sports cardiologists, so cardiologists who just work with sports teams. They're adult congenital cardiologists. So they work with adults who had heart problems in their childhood, and then they still need care when they're adults. So they specialize in that. There's also heart failure and heart transplant cardiologists. So in other words, they specialize in managing people who have really, really bad heart. So they're at the opposite spectrum of prevention. They're at the end where it's like if someone has a really bad heart and if they're being considered for transplant, they're specialists who focus on that. And then we also have the electricians of the heart, the EP cardiologists, and they really focus on the electrical system of the heart. So we just introduced you to a small speckle of the opportunities that are available in the field of cardiology. And hopefully you guys enjoyed it. Back.
Yes, thank you so much. And I think we have a little bit of time for a couple more questions. So if anyone has any final questions, they can put them in the chat. I was just wondering, really for all of you, and specifically with the cath lab, are the outcomes typically positive? And if they're not, which is an aspect of going into medicine, how do you support each other and keep your mental health in check in those difficult times?
The majority of our cases have good outcomes. And, you know, there is the occasional case that doesn't end well. And, you know, the realization is we're dealing with really, really sick patients that come in. A lot of times people come in shock. They're, you know, barely alive when they get to us. And, you know, it's really hard to kind of deal with situations like this, especially when they seem to come in clusters sometimes together. You know, it's just really important to kind of like talk about these things. We typically have like a morbidity mortality conference or a Q&A that we have once a month with interventional cardiology. And we all kind of go, all the interventional cardiologists, all the fellows, all the nursing staff, and we kind of talk about all kind of the bad outcome cases of the month. There's usually not a lot, but we do spend like 30 minutes to an hour talking about kind of all the bad cases. Could we have done anything better? You know, what the outcomes were. And it's kind of like a little bit of a debrief for all of us. So I think it's just really important to kind of talk to people. And like, if you're struggling or anyone else is struggling, you know, they have people to reach out to. So I think that's important.
Thank you. Yeah, it's obviously a reality of healthcare in general. I also had a question just in terms of, you know, and in the case that the three of you just presented, what does the typical timeline kind of look like for when a patient comes in, the imaging and the echo is done, where then the outcome is, you know, placing or in the cath lab and then placing this shunt or stent or whatever it is? What does that typical timeline kind of look like?
So for if we use heart attacks as an example, or myocardial infarctions as an example, there is almost like a spectrum of heart attacks. Some people come in and they're very ill. So in other words, they're having a very serious heart attack where there is complete blockage of one of the arteries that supplies blood flow to the heart. Usually we call those STEMIs. And that's when we wake Kat up in the middle of the night and she gets to rush to the hospital. And a lot of times we end up with those patients who are much more ill and who are showing us evidence that there is full or complete blockage. When we see patients like that, the timeline is obviously much more abbreviated. People do come into the ER. We see signs saying that the artery is fully blocked, and for those patients, they go directly to the cath lab. So we do not stop and do imaging for those patients. For some other patients, they come in with a more subtle presentation. So in other words, they have that chest pain, they have some changes on their labs. Everything is suggestive that they're having a heart attack, but there's nothing to say that we are concerned that the complete artery is blocked. Maybe a portion is blocked. And for those patients, then we might follow the timeline that we kind of presented with that case. So in other words, someone sees them in the ER, they look at all of that information. We get our scans, we get all of our information together. And when we are sure that the true diagnosis is a possible blockage, or when we are when the information says that the diagnosis is a possible blockage, then we go to the cath lab. So there's a spectrum of the timeline depending on how the patient presents.
Thank you so much. And then we have a question from the chat. What's the difference between cardiology and cardiothoracic surgery? So what would those different career paths look like?
That's a great question. There is a big difference between the cardiothoracic surgeons and us in cardiology. The cardiothoracic surgeons are surgeons. So in other words, they do active surgeries where they're going through the body, like with a scalpel and doing surgeries. For us, we do not do surgical procedures. As like Kat does, we do interventional procedures where we go through blood vessels to get access to the heart, but we just don't do full surgeries on the heart. The pathway to cardiothoracic surgery would be different than what you saw with kind of like my pathway through medical school. For the cardiothoracic surgeon, they go to medical school for the same 4 years, obviously. But when they come out of medical school, they usually either go into a dedicated cardiothoracic surgery residency, or they start with general surgery first for residency and then specialize in cardiothoracic surgery. So there are very specific, very different fields, and we do have different roles. So our cardiothoracic surgeons are doing things like surgically fixing the valves, Or they're also doing things like doing bypass surgery. So in other words, if Kat took some pictures of the arteries and we see a lot of blockages that we can't fix with stents, a lot of the times we'll get our cardiothoracic surgeons to look at the patient and see if they're candidates for getting bypass surgery, where they actually go in, open up the chest, take vessels from different parts of the bodies and bypass those blockages. So for example, with what Kat shows with that blockage on the right, they would almost like sew a little vessel to the, before the blockage, or I should say, they would sew a little vessel to the aorta and they would bring blood flow to beyond that blockage. So yes, very different fields, but still all cardiology.
Okay, great. And then we kind of have a two-parter question up next. The first is, are there any PAs currently working in cardiology at the UVM Med Center? And for Will, how often do you have to go into the hospital when you are on call?
I can answer the first part and then you get the second part, Will. We do have 2 PAs in cardiology right now, and I think we just hired a third. We basically all fall under this umbrella called APPs, or Advanced Practice Providers. And so this kind of just is your physician kind of counterparts of nurse practitioners and PAs. So currently right now in cardiology, I think we probably have about 10 APPs, and that's between the inpatient and outpatient settings. And so kind of we all work together in kind of various different subspecialties to manage patients.
Perfect. And then for the second part of that question, if we're on call, weeknights, rare, but it happens probably once every 2 to 3 weeks on weeknights. Weekends, Saturdays and Sundays, unfortunately, if you're on call, if you're going in Saturday, there's no doubt about it. Sundays, definitely more so lately because more patients have been coming back in the hospital lately. But say Saturdays, anywhere between 4 and 8 patients, and Sundays, maybe 2 or 3.
Thank you. And then I'll ask just a final question, kind of a soft question, but for all 3 of you, what's your favorite part about working in cardiology and or working at UVM Medical Center?
My favorite, I think I have multiple favorites. So my favorite part about working at UVM would definitely be the people, and would be the kind of like the opportunities I've gotten to work with some really extraordinary individuals, whether it is that they excel in their field, or whether it just be like people I can just get along with and kind of share my passion with. So for the UVM part, I would definitely say the people. For the field of cardiology, for me, I would say for me, it would be the patients. My patient encounters are the thing that really is one of the most, I guess, is the best part of being able to do what I do, is actually getting to speak to patients and like having those moments where they really understand what's going on with their body and they feel empowered to actually go forward and manage it kind of either by themselves or jointly with us as a team.
Yeah, for me, I agree with Cecile. My favorite part about UVM is definitely the people. We are a fun group of people to work with. And as far as kind of my favorite part about cardiology, I really like how it's, you know, always like up and coming. Like there's so much new research and data coming out constantly, and everything's so innovative, and we're doing such crazy things that if somebody told you like 20 years ago that we'd be doing this, you'd be like, you're crazy, but like we're doing it. And, you know, every day, like we're learning new things and, you know, just basically making care better for patients. So I think I just like, you know, the innovation.
Yeah, for me personally, working at UVM, I think my favorite part about working here is that it's a level 1 trauma center. So you get to see all this, you know, diversity throughout the entire hospital, and specifically in cardiology, like Kat was saying, you're seeing all these crazy fun cases that are coming through, and like, you know, fixing them in fun and unusual ways, because you know these are cases that go to hospitals, they don't know what to do with them, so they come to us because we have these specialists who know how to deal with this or who can figure out what to do with. I mean, we have one doctor, Dr. Harry Darman, incredible man, Dr. Terrian as well. They're just the things they do sometimes just seems impossible, like they're magicians or something, but they just fix hearts or do something like insane. And then working in cardiology personally is getting to say I work in cardiology. No, for working in cardiology, I think it's working with other people who also work in cardiology. So when you do have these fun and unusual cases, you can kind of like freak out a little bit, but in a good way, and say, oh, check out this interesting case I have. What did you think about it? What do you think we could do, or what we could possibly do in the future to save people or help them? So.
Well, thank you so much, all three of you, for being here tonight and donating your time. It means so much to us. This was a fantastic panel. And I just thank you again. Our next panel is going to be October 21st, which is the third Thursday. And we'll actually be having our panels on the third Thursday of the month for the next 3 months and possibly further than that with holiday seasons coming up. And so we will be featuring Dr. Mariquin, a transplant surgeon, and Dr. Wilcox, a pathologist. So that will be an extremely interesting session as well. And we will send our email reminders. So thank you so much for coming and being here tonight. That is all.
Thank you.
Thank you again, everyone. Enjoy the rest of your night.
Bye-bye.
Thank you, everyone.